We're going on with neuroimaging and aphasia, and yesterday we focused more on the aphasia part of the title, and we discussed the definition of aphasia, two different classifications of aphasia syndromes. I gave an overview of functional organization of aphasia and the role of the right and left hemisphere organization. We discussed some paper examples, and you successfully fulfilled the exercise. Today we'll focus on neuroimaging. And although of course I'm a linguist, I'm not a radiologist, but I'll try to introduce you some basic principles of fMRI, because you have to be aware of what is the basis, what's your measure, and because some of the principles of fMRI measurements you collect influence your design and paradigm. And we'll discuss, because it's neuroimaging and aphasia, we'll discuss language applications of fMRI, and basically how difficult it is when you study language. Then even more, we'll focus on pitfalls of using fMRI technique in aphasic patients. We'll discuss again a couple of examples, and you'll do an exercise, and more sophisticated today. And as follows from this slide, people wanted to know what's going on in the brain from long ago. And fortunately, you could see that they even made a kind of arts of that. Fortunately, we have a few non-invasive techniques which allow us to detect and interpret the work of the brain in living brain. So some basics of fMRI. The most basic concept is what you measure. What is the effect that allows you to measure brain activity? This is bold oxygen level dependent contrast. Sorry, a Russian word was introduced in this slide to some reason. And this is the bold effect, and this is what we basically measure. It arises as one of the stages launched by cognitive process itself a person has to perform. So let's say you have a cognitive process, some kind of language task in our case. To perform a cognitive process, your neurons should work, of course, and this neural response causes physiological changes, and we'll go to that in the next slide. But basically, it is the principle, which is when a part of the brain works, more blood is supplied to this part. So, and it is related to the dilation of vessels and increased blood flow to this region. Then, because of the increased blood flow, the ratio of oxygenated blood and deoxygenated blood changes. And this is what causes a MR signal change. And it is related to the notion of neurovascular coupling. It's neuro because it comes from the work of a neuron, and this is vascular because the work of the neuron causes some vascular reaction, namely dilation and blood flow increase. So this is just for you to know, this is the molecule of hemoglobin, and it what it does is it transports oxygen to its destination, let's say to some brain region which performs language function in our case. And one molecule of hemoglobin contains 4 the so-called heme groups. This is ferrum. It can attract oxygen, and this is how oxygen is delivered in the brain and also in other tissues, of course. And magnetic response detected by the scanner depends on the oxygenation level of the blood supplied to a brain region. The difference between oxygenated hemoglobin and deoxygenated hemoglobin is very simple. The oxygenated hemoglobin is isomagnetic, so it produces no net magnetization. So if you put an oxygenated hemoglobin in a magnetic field, it will not disturb it. In contrast, deoxygenated hemoglobin is paramagnetic and it produces net magnetization. This is why if you put deoxygenated hemoglobin in a magnetic field, it will strongly disturb it. And the more deoxygenated hemoglobin blood contains, the more disturbed the magnetic field is. And this is what happens at the level of blood vessels. This is a resting state. So this is blood. White dots are oxygen supplied to a neuron. A neuron consumes oxygen, but there is some oxygen left in any case. Not that much as it comes to the neuron, but still. At the first phase of neuronal reaction to a cognitive task, a neuron consumes much more oxygen than in the resting state. This is why no oxygen is here. All is consumed. And it causes a decrease of MR signal because more deoxygenated hemoglobin means more disturbed magnetic field, so less MR signal. This is why we have a very short dip here. This is the whole ball direction, how it develops over time. But then this phase is very short. And the main phase is, and this is what we basically measure in fMRI. Vessels react to high level of consumption of oxygen, of course. So vessels dilate, and more oxygen is supplied. Sorry, where's the mouse? The more oxygen is supplied to a neuron, but still a lot of oxygen is left, non-consumed. So the ratio of oxygenated and deoxygenated hemoglobin changes. There is less deoxygenated because there is oxygen everywhere here, and the MR signal strongly increases, and we can measure it. So, and contrasting two conditions, the activation condition and the control condition, say resting state, we see the difference. And this is what we measure in the fMRI. And it can be visualized in pictures like this. And there are some, of course, as with any technique, there are some pros and cons of using fMRI. fMRI has a relatively good spatial resolution up to millimeters, in contrast to EEG or MEG, where localization task is not fully resolved at the moment. It is non-invasive in contrast to positron emission tomography. It allows to correlate hemodynamic responses with behavioral measure, because we can divide behavioral responses, correct and incorrect trials, and see what is the brain reaction in each case. This is because we can do event-related fMRI. We'll talk about it later. There is, of course, increasing availability of fMRI, because it might not be necessarily installed in clinical setting. And fMRI shows, because we scan the whole brain, usually we scan the whole brain, it shows the entire brain network involved in a cognitive task, which is very important for us as linguists. But of course there are some contrasts. Hemodynamic response is not the work of neurons itself. So fMRI signal is a surrogate of hemodynamic activity. There is some additional step and assumption we should do when we interpret fMRI data. So this is, you should always remember that this is not the work of neurons. This is the reaction of blood vessels and increase in blood flow. Of course, the very related process, but actually it means, if you go a little bit deeper, it means that when you think when blood flow increases, it's excitation or inhibition in the brain. It doesn't matter. It all depends on neuromediators. So you don't know the nature of the process which occurs in the brain. There is some work of neurons, and it is there is increase in blood flow. This is all that you know. So there is quite some assumptions behind the technique. So we don't know if it's excitation, if the increase in blood flow and the ratio of oxygenated and deoxygenated hemoglobin is caused by excitation or inhibition. And as with many other techniques, it is a correlational measure only. We cannot set causalities on the basis of fMRI data. And I said that fMRI has relatively good spatial resolution, but still not perfect, to the extent that we cannot differentiate between between brain activity related to different tasks if it occurs in the same region, but it's slightly different in each case. Still, it's not that good spatial resolution. And of course, there are some design limitations, for example, related to acoustic noise produced by the scanner. This is why patients might prefer a silent positron emission tomograph. Language applications of fMRI. fMRI allows us to study speech production and comprehension, both, with different kinds of difficulties we experience when we do that. At different linguistic levels, from the phoneme level to the discourse level, we can do different kinds of designs, including blocking our stimuli or we can do event-related design. I'll explain it a little bit later. We're free to use different baselines. Usually, it's the basic logic of data analysis is subtraction. You subtract control condition from the experimental condition, but you can use different control conditions. The ideal situation is when you subtract everything from the experimental condition which is not important for your research question. For example, you study a word retrieval, and you want to subtract motor response, visual analysis, whatsoever. And the fMRI can be used, of course, for experimental purposes, as we do, and but also it has some clinical promises. I will give you an example of a continuous acquisition and block design. So these are two different things. We can collect data like every 2 or 3 seconds, and actually it produces a specific sound. This is what produces a specific sound in the scanner. But we do it throughout the whole experiment. And this is a block of your stimuli. So they're packed in one block. Let's say 10 stimuli here, each lasting 3 seconds. So in total, it's 30 seconds of a stimuli presentation. Then there is a rest condition. Then your stimulation, and then there is a rest condition. But you acquire brain images all the time, every 2 or 3 seconds. And this is the logic of subtraction. So if this is experimental condition, this is a control condition, you subtract this from this, and you get this activation related to the difference between experimental and control condition. Regarding the baseline problem, it is up to you, and it very depends on your research question, which kind of baseline you should use. If your experimental condition is related to visual presentation of real objects, then you might choose a high-level baseline, let's say non-existing objects. And if the task is naming, then you are focusing on the naming, this is what you want to disentangle. Then presenting non-existing visual stimuli will allow you to subtract visual activity to some extent. Or you might use really a resting state, just passively looking at the cross. There is some visual activity here as well, so this is why it's low-level baseline. Or people just use an empty screen. This is doing nothing, and participants are instructed in this case try to not to think about anything, which is a very hard task, I should say. So this is again the conventional block design with continuous acquisition, but we might choose another kind of acquisition paradigm when we need, for example, to deliver a linguistic acoustic stimuli to a participant, and then the noise is very disturbing, and it's hard for a person to, for example, to discriminate phonemes in a scanner noise. This is why we want to introduce some periods of silence. So basically what we do then, we're presenting stimuli in a block, for example, several of them. Then there is no scanning. We do not collect data at that moment. Sorry. This is the silent period. Let me be concrete. If it's an object naming task, then you're presenting a picture here, and a participant should name a picture. And there is no data acquisition at this moment. There is silence. We can collect data, for example, or in another kind of paradigm, you could deliver in this period an acoustic stimuli, for example, phoneme of words or sentences. And then you scan. So you scan after you delivered a stimuli or you collected a stimuli in a silence. We discussed all that were examples of block designs. This is event-related design. So our measurement is locked to a particular stimulus. So this is block, and this is a single event. And this is a reaction to a single event, a bold response to a single event. You can see the difference. If we present stimuli in blocks, and actually it is very important for studying aphasia, then the activation is summated. So it reached a kind of plateau and lasts during the whole block. And then there is a resting state, it goes to the baseline, and then it is summated again. So this is a more robust measure than in case of event-related designs. But people in psycholinguistics, people often choose event-related design because they want the reaction to a particular stimuli. Block design, for example, does not allow you to differentiate between correct and incorrect answered trials. And here we come to problems. This is a typical fMRI environment. So there is acoustic noise, there is lying position, not a very common position to produce language or to do some sophisticated cognitive tasks. Usually the head is immobilized as much as we can to immobilize it. And when a patient still, if it's immobilized enough with different kinds of pillows, if a participant moves with the jaw, for example, produces speech basically, then there are movement artifacts. And what some people do, I'm not sure if there is this kind of practice in this country, but I know they did it in Holland at some point. They used a foam to immobilize the upper part of the head, and then the jaw is free, and this part doesn't move where the brain is, which is important, and we speak with the jaw, and then it's perfectly fine. Movements are gone. And because of the lying position and because the head should be in the scanner, we use a sophisticated set of mirrors to deliver visual stimuli, for example. And this is not very convenient for a participant. And actually, there is limited visibility. And we need a high number of measurements to get a statistically robust results. And therefore, we need many trials, but the length of the experiment, of course, is limited. It is impossible to keep a healthy person in scanner more than an hour, usually. It's because there is no attention in the end, and you don't know what you measure. With using fMRI in aphasic patients, it's even worse, I should tell you. But there are some tools. As I said before, there are some solutions that it is advised to use a block design to get a more robust measure, for example. And concerning different kinds of designs, it is advised to use factorial design when you, for example, manipulate both kinds of stimuli and the task. And then using different kinds of statistical approaches, you can disentangle the different processes. And factorial design, I will give you an example to clear it. Factorial design is especially appropriate for studying functional integration. There is a kind of differentiation between functional segregation and functional integration, and it is very related to studying language and aphasia. Oh, sorry. This is an example of functional segregation. So this is a task in which two parts of the brain, say A1 and A2, participate, and this is task 2, where two different parts of the brain are involved, B1 and B2. And when this part of the brain is damaged, then a patient cannot perform the whole task, as healthy people do. And from this kind of paradigm and design, implementation and data analysis, we can infer about functional segregation. How it is basically related to specific functions of each part of the brain. It's more about localization of functions. But what is more interesting, and what basically occurs in the brain, because it's a complex system, is functional integration. So we have 4 tasks now. This is our task 1 with 2 parts participating. This is task 2 with 2 different parts participating. But then there is task 3, which involves A1 and A3, and task 4, which involves A2 and A4, because different parts of the brain, of course, combine to perform different functions, and this is the reality. But then, if, say, A1 is disturbed, then what we might observe, that this task, which was number 3, cannot be performed, but this task, to some reason, can. And then we infer about the role of each part of the brain in different tasks, the contribution of a part of the brain, which is different depending on the task. This is why factorial design can help you. So yeah, you use different tasks, different stimuli, and you are focusing on different parts of the brain. Yes, this is a very simple point, but very important. Not every task is easy to perform in patients, and you should always try to make sure that patients perform the task. If it is a silent task, I wouldn't call it a nice design, because you don't know what you measure, basically. Let me give you an example. If we study reading process in, say, dyslexic patients with acquired dyslexia and healthy readers, then we might get a reduced activation in patients in some region, where there was very large and extensive activation in healthy participants. But it might be due to two different reasons. Either due to the fact that this particular area is not functioning properly, that its function is compromised, or because it doesn't get the proper input from another compromised area, and we just don't know. So the advice, the solution is actually to recruit patients with good performance to make them comparable to healthy participants, or at least to recruit two different groups of patients, one with one good performance and one poor performance. And another solution is to vary task difficulty systematically. Then you can model the confounds statistically. And you might use implicit paradigms, actually, when the target function is not addressed directly, but rather indirectly. For example, if you're interested in, it is not very related to aphasia, but I find it a nice example. If you're interested in processing emotions, you might not directly ask your participants to judge emotions. Just present them visual stimuli, and the task will be to name them. So the emotion reactions will come, but you will not address it directly. So you just ask to name all kinds of pictures, faces, for example, or, I don't know, animals in different states. But only you know that there are two kinds of stimuli, emotional and non-emotional. And then you do your statistics and you get the result. The participant doesn't know that. Presentation parameters are very important. Just let me remind you the time course of hemodynamic response to a stimuli. It peaks at actually 4, 5, 6 seconds, and you remember the high peak. And it returns to baseline after 10 seconds and fully comes to the baseline more close to 15. And presentation in close succession increases the amplitude of the signal due to summation. This is the logic of block design, and this is why we should use it in single case studies like we do in aphasia. Yes, block designs are more sensitive. At the same time, the rate of stimuli presentation is also important. Interstimulus interval stands for that abbreviation, should be long enough to optimize the number of correct responses, just because your patients might not have enough time to respond if you present pictures too quickly. But interstimulus interval at the same time should be short enough to maximize signal. Otherwise, your block design will become event related if you put stimuli too long apart. These are nice graphs showing the hemodynamic response to single events. You see the peaks, single peaks, locked to the single events, but shifted a little bit due to delay in peaking of hemodynamic response. These are blocks basically, and you see the summation, very nice. And these are basically single events with very short interstimulus interval. And it is widely used in psycholinguistics, in group studies, but it is not advised to use it in aphasia, because in aphasia you usually study single subjects separately, and there is not enough statistical power to in this kind of data. Okay, why group analysis is a very sophisticated matter, because even if you group, if you make group of patients with very similar lesions, say your target is inferior frontal lobe, Broca's area. Still, patients vary in shape and size of the lesion. It is extremely individual. And you will never be able to find, of course, patients with the same, just the same lesion. It's like fingerprints. And this is why perilesional activation is very unlikely to detect in groups of patients. Lesions are different in shape and size a little bit. So when you do group statistics, there is not enough statistical power for the activation which when lesions do not overlap in the regions where lesions do not overlap. So you just don't get perilesional activation just because of this fact. And inconsistent activation in patients may also cause false positive average differences between patients and healthy controls. And this is again because you do not detect all activations presented in patients, and you find that in one region, in a group study, at the group level, you do not find activation in a group of patients, but you find a nice activation in healthy participants. And you immediately infer that this is a compromised region, which is not, you just didn't detect the signal. The advice is to model each patient as a single case study and increase data points as much as you can. Again, taking into account that you cannot keep a patient in the scanner for too long. An interesting fact is related to specificity of neurovascular response, which sometimes occurs in patients, and this is why you should screen for these things before you recruit your participants, before you put them in the scanner actually. For example, the process of neurovascular coupling, the reaction of vessels to the work of neurons might be just disrupted. It, for example, occurs in the disease which is called extracranial carotid stenosis, when it is when the carotid artery is too narrow due to, for example, blood clots, and of course, brain needs its nutrition. This is why the vessels in the brain are more dilated all the time than in control participant, for example. So there is an increased blood flow in the brain because of dilated vessels, comparing to the normal state, for example, in this particular patient. So the vessels, the main thing is the vessels are always delayed, and this is the process that provides the neurons with nutrition, and neurons work properly because of that, because of this abnormal vessel reaction. But the reactivity of vessels is very reduced. They're all the time dilated. So the dilation of your vessels is not related anymore to the work of neuron. So the whole process of neurovascular coupling, which is in the basis of MRI measurements, is disrupted. So you should screen for this kind of factors before you recruit participants. And I was asked to make a break to check the batteries. Yeah? Just 2-minute breaks. Нормально? Ну, еще у нас чуть-чуть. Ну, я думаю, не больше получаса. Даже меньше, наверное. Татьяна Владимировна, а у нас Наташа в 12:30 начинается же? У нас оказывается... Что? Нет, я хотела спросить, во сколько начинается следующее. А, вы сколько сказали? Нет, все запутались. Сколько поезд? А мы с вами пойдем. Что-что?
Филфачные студенты наши. Да, здесь съемка идет. Тоже на чуть-чуть.
Да. 12:45. Ну у нас там даже будет такой большой перерыв сейчас тогда. Мы с вами поговорим.
Да, я же туда не tengo.
Let me go on. Similarly to what we did yesterday when we discussed a couple of papers in terms of different kinds of neural reorganization after the stroke in those cases and in case of aphasia. We'll discuss a couple of papers now, but we'll focus on the technical part, basically on the paradigm. And these are, I think, nice examples, and this is what's on the market. And the authors are successful researchers in the field. So I strongly advise you to read the papers afterwards. And for those who didn't hear that, I copied all the papers in the folder on the desktop. Yeah, the first paper was on French. And they used, the task was, actually, they focused on object naming, but used a very nice, from my point of view, a very nice control condition. So the stimuli were object or animal pictures, and on the one hand, on the other hand, they were written frequent words, and the length of the words was controlled, and they had two activation conditions: a word picture naming, when pictures were presenting and a participant had to name a picture, and the second task was to say if the presented written word is and the name of the picture presenting on the same slide are rhyming or not. And the participants had to produce an oral response, yes or no. For example, for the picture of chicken, it was needed to say if it's rhyming with the children, and the picture for the picture of the knife with hat, for example, which is not rhyming. The rhyming task was chosen as a control for picture naming because this task, it is not ideal, I should tell you, but still it's nice. It's better than presenting a cross. Definitely. Because a rhyming task and object naming task share, for example, phonological form retrieval, and this is what the authors wanted to subtract, for example. But rhyming task requires the form retrieval without multiplaning and production of this word. Although yes and no were produced too, so some part of motor reaction was also subtracted. And 4 runs, the stimuli were packed in 4 runs, 2 runs per each task. And the authors used block design. So 1 block included 5 stimuli. Each stimulus lasted 4 seconds with 2-second stimuli interval. So the total length of the block was 30 seconds. And because this is an aphasia study, of course, they were interested in pre- and post-therapy effects. What they did in the analysis, they collapsed, of course, all responses because it is a block design. They couldn't differentiate between hemodynamic response to correct and incorrect trials. And they contrasted naming to rest. Rest was doing nothing in their case. And rhyming task to rest. Then, of course, actually they contrasted naming to rhyming. They made a contrast between in all those conditions before and after therapy, and they studied a single patient and a small group of control participants, so they compared the activation in this patient in contrast to controls. This is what you can do with block designs, therapy applied to a patient, and with 2 different kinds of activation conditions. Another example is about bilingual aphasia again, and this is the author who is doing a lot in the field of bilingual aphasia, for those who is interested. Their participant was a Spanish-Italian bilingual speaker, and they used picture naming in his L1, which is Spanish, and L2, which is Italian in his case. They scanned him before therapy, after deficit-specific therapy. The patient had severe anomia, so but phonemic cues helped him, and this kind of therapy, deficit-specific therapy, focused on giving him phonemic cues and training word retrieval in this way. So they also scanned after this specific therapy, and then they applied global therapy with different kinds of tasks, object naming, saying word to definition, playing with the synonyms and antonyms whatsoever, reading, writing, and they tested after global therapy. And they used event-related paradigm. So they measured the response locked to each trial, to each picture with a response to it. Each run consisted of 40 images to be named. Actually, it is a tradition, and it makes very much sense to deliver your stimuli in at least 2 experimental sessions with a break between them in fMRI experiments. Especially it's important in aphasia, because if there is too many movements within a session, then you have just to throw out the data. But if you divide your whole experiment into multiple sessions, then you have all the other sessions survived. So don't pack too much one session. And since this team mainly consists of linguists, they controlled a lot the stimuli, and they matched, for example, for word length, number of syllables, and frequency in both languages. So not only, and of course they matched for those variables within runs, for example, and those properties of words were the same in 2 languages. And how it was actually presented. A picture was presented for this time, then naming aloud followed, and interstimulus interval was jittered. And actually, jittery interstimulus interval is a solution to be able to analyze event-related data further. And oral responses were recorded. So in principle, the authors could differentiate between correct and incorrect trials, which they tried. But in the end, they ended up with too low statistical power, as I mentioned before. So what they did to prove that they are allowed to collapse all responses, they did a validity check. They compared all responses with correct naming trials, proved that the activation is the same, but it's stronger when we collapse all trials. This is why they analyzed all responses collapsed in the end. And the contrasts which they did were between L1, of course, and L2. Because the therapy was delivered only in L2. This is why they were that interested in that. And they contrasted effects of different kinds of therapies. Also, the contrast, the direct contrast between therapies, and they contrasted each theory to pre-therapy baseline. And the last paper I just cannot help mentioning is a very famous work of R.G. Hillis and her study of hyperperfusion. Basically, the traditional fMRI experiments we do use one kind of scanning sequences. This is the so-called diffusion weighted. I won't go into details, but this is what we do all the time in fMRI studies. But still, using the same scanner, you can apply a different sequence and measure perfusion weighted contrasts. And this kind of measurement allows you to detect the perfusion of blood in different regions and how it changes with time. So what they did, they recruited 87 patients. So it's a study with very high statistical power, with impaired picture naming. And they identified areas of hyperperfusion, the areas which were not supplied well with blood. And these patients were all in acute stage. Actually, they were scanned for the first time, maybe just right after they got the stroke. So they measured both their structural damage, where the brain tissue died forever, and they measured hyperperfusion. So the tissue survived, but it was not supplied enough with blood. So this is why, of course, it was not functioning properly. And after the first scanning, medical intervention was applied to reperfuse those areas which were not supplied enough with blood before. And then they made another scanning, and in this simple way they found, they identified the areas, reperfusion of which is critical for this particular linguistic task. And not very surprisingly, we got left posterior temporal and fusiform gyrus, Broca's area, and Wernicke area. This is I find it extremely interesting because these are exactly three areas which are only them were named central for the whole linguistic processing in the brain according to the traditional, and we think now outdated, but this data proves that it is not, the model of Wernicke-Lichtheim. And there's exactly those three areas, and they're critically important for the restoration of blood to those areas is critically important for performing linguistic function. Okay, and an exercise. How many of you are familiar with this kind of scheme describing two kinds of dyslexia? Just raise your hand if you ever saw it. Okay, then I'll tell a few words. This is the model for one of the models for reading words. Sorry. For reading words. Say you have to read the word naming. And these are the stages you should go through according to this model. First, you analyze this object, written object, visually. Then you should find the appropriate word, the corresponding word in your visual input lexicon. Then it goes to semantic system where you understand what's written. And then it should go to speech output lexicon, which in this model are modeled separately. And then it goes to phonological buffer where all phonemes go into sequence and you produce an acoustic signal. This is your reading. And there are two different kinds of dyslexia. Surface dyslexia, where the pathway from visual analysis to visual input lexicon, the access to visual input lexicon is compromised. It is not the case that it's absolutely gone, just it's more costly to access a word, and this is why different kinds of errors occurs. And so this way is compromised. This is why people with surface dyslexia, according to this model, go in this way. Because we can read a word without understanding what it means. But going from visual analysis to phonological buffer requires the knowledge about correspondence between a letter and a phoneme. And this is the way how we can easily read regular words, because there is a regular correspondence, but there is no way to read in this way irregular words. And I wonder if you have irregular words in Finnish.
Finnish is we have by phonological writing system.
So everything is very regular?
Yeah.
Okay.
It's very transparent, but you pronounce.
Okay, so yeah, then you might read. You might read Finnish words, or I might read Finnish words, just using this indirect pathway. Of course, I will not understand anything, but I can do it if I am trained enough. And this is surface dyslexia, because you use the surface pathway. And another kind of this dyslexia is in contrast, when this pathway is compromised, and then you are obliged to go through the whole system. And, but it means that, of course, using this system, you can read both regular and irregular words, no problem, because they are all are words of your language, and they are in your lexicon. This is perfectly fine. But, for example, if I test pseudo words reading, the patient will never be able to read them, because it is not in the lexicon, there is no meaning, so just the word can go through. And this is called phonological dyslexia. And actually the task for you is, if this is the theoretical model, and it nicely describes models, the mechanisms, psychological mechanisms of two different kinds of dyslexia. And the task for you is to design a paradigm to study neural reorganization of reading in patients with acquired, let's say, surface dyslexia. So they always use, sorry, what's wrong with it? Yeah, those patients always read the surface pathway. And yeah, the task is to design an fMRI paradigm. And since I think it is not very productive to do it in groups now, this will be a home task. And later, I provide you the first step for this. This is actually an idea for your first fMRI study, because it was never done in patients, but a similar study was done in healthy participants, and in this paper they dissociated those two pathways on the brain level in healthy participants. And there is some data here. So this is your home task. Thank you very much.
Thank you, Olga. And so, any questions or comments?
Yep.
I have a technical question. If speaking during the fMRI session is possible, why some researchers, why they use some silent reading techniques, silent prognosis techniques?
Even if saying aloud is that problematic, why don't they use silent?
Because of what?
We need, they use,
possible,
it is possible, but still,
But there is some studies in which main paradigm is to imagine words, not to speak aloud.
yeah, there are a lot of works like that, and when people started doing fMRI with speech production, they used a silent production a lot, and they still keep on doing that, but we cannot control the response. I'm not sure that my participant is performing the task.
Yes, but why do they do that?
Because they are afraid.
They don't. Yeah, this is the price.
It's still possible to.
Yeah. Actually, it's more or less appropriate in healthy participants when you pay them, when you train them, and then when the results you get in the end are in line with your hypothesis. Because if you had a very straightforward hypothesis and you got the confirmation in the data, then it's very improbable that it's due to chance performance of 20 or 30 participants. Yep. So we should pay the price all the time. There is no free lunch.
Any more questions or again comments? Then we should
Thank you very much. It was my pleasure. It was really my pleasure to present you a couple of lectures, and I hope you will at the end of the school you will be inspired enough to get into the field. You're very welcome to contact me, by the way.
Thank you for your wonderful lectures. Yes, we're happy to have you here. Come frequent.
I will try. If you invite me, I will. Thank you very much.
Thanks a lot, and we